The school reached out to us early in the school year about an elementary school-age child who was fairly disruptive in class. And not only was he disruptive, he was actually missing days of school. And when the mother was reached out to, she stated that she thinks her child has autism and she has difficulty getting him to school. The opportunity of our mobile clinic is that we have experts in developmental behavioral pediatrics, and we invited the student to come with his mother to our clinic. And we were able to immediately diagnose this student with autism and put the word out to his school. We included educational accommodations for his autism and also forwarded the recommendations of his autism diagnosis to his primary care provider, who we then later found out had struggled getting referrals to the developmental behavioral pediatrician because the pediatrician also thought he had autism but couldn't make the diagnosis themselves. So ultimately what happened is because of our moment together, we were able to meet each other and make the diagnosis of autism for this elementary school-age child. Then the rest of the roadmap of autism resources started opening up for this child and this family. As a result of the safe environment that we were able to establish on the mobile clinic, Mother was able to open up to us that in addition to her child having potentially autism, they were recently kicked out of their home and they were living in their car. And so we were able to support the family in their current unhoused situation and let the school know about their unhoused situation and really engage our school partner.
Welcome to EM Pulse, bringing research and expert opinion to the bedside.
We're your hosts, Sarah Medeiros
and Julia Magaña. Welcome back to EM Pulse. Today, we move on to the next episode in our multi-part series on taking medicine to where our patients are instead of them coming to us, or medicine on the go. If you have not heard it, take a minute to go back and listen to our innovative pre-hospital care episode. It really is interesting. Every shift, I see a handful, or frankly more, of kids who I think, man, if you could just see your pediatrician, I'm pretty sure that they could do this. Or even if only you'd been able to get help earlier, this would not be so bad. But there are innumerable barriers patients have to seeking primary care. From time to transportation to cost, or heck, even getting an appointment in the overcrowded primary care world. This episode explores how one group is tearing down these barriers, meeting kids at school, in their community, and helping to prevent those very thoughts that I have every single shift. Dr. Serena Yang is a colleague and mentor of mine. She is a professor of pediatrics at UC Davis, division chief of general pediatrics, and physician lead for the Pediatric Mobile Clinic at UC Davis Children's Hospital. Welcome, Serena.
Thanks, Julia, for having me.
Okay, Serena, tell me, what is exactly UC Davis Children's Hospital Pediatric Mobile Clinic? I mean, I can kind of get an idea of like this bus driving up to a school and the kids lining up to be seen. But tell me, what does this look like?
Well, first of all, before we get any further, students have come up to our van, like opening up their arms and giving us blood. Like, where can we give blood? And so for the record, we're not a bloodmobile. But just to get back on track, the Pediatric Mobile Clinic from UC Davis Children's Hospital brings pediatric specialty consultations in child development and behavior, mental health, and asthma to those historically under-resourced neighborhoods in Sacramento and surrounding communities. Our goal, Julia, is to partner with families, primary care providers, schools, neighborhood centers, and other community-based organizations to identify children with these specialty healthcare needs and connect them to resources in their local areas.
Yeah, I think that's amazing and really leans into UC Davis's strengths of our subspecialists. And we have so many wonderful opportunities and resources that other places don't have and that patients don't always have access to, that I think I can think of a lot of really important reasons why this clinic came into creation. But can you give us a little background? Like, why was this mobile unit created?
As we're now finishing our first year of taking our mobile clinic into the school community, I wanted to share why we decided to focus on supporting the health of children in these three areas of child development, mental health, and asthma. So with child development, this is in other words how children play, speak, learn, act, and move for their age. We know that 1 in 22 4-year-olds in California are on the autism spectrum.
Wow.
So this reinforces the importance of early identification of children with neurodevelopmental differences and then connecting them early with the appropriate health and educational supports, right? The second area of focus is mental health. Why mental health? In California, it's estimated that 1/3 of 7th graders report chronic sadness and social emotional distress, and 1 in 7 7th graders have considered suicide. Think about that.
That's devastating.
And thirdly, our area of focus is asthma. Guess it goes without saying, you're an emergency medicine doc, you can appreciate that one of the most common health-related causes of school absence is asthma.
Yeah.
Students with asthma miss 3 times more school than students who don't have a diagnosis of asthma.
Wow, that is devastating.
So the idea of a pediatric mobile clinic for under-resourced areas of Sacramento was actually originally conceptualized 4 years ago by a group of passionate medical students at UC Davis School of Medicine. These students wanted to bring pediatric care into the community, right? So they brought the idea to us at the Children's Hospital, the faculty members, and with our support, the medical students, were able to successfully secure a grant from Children's Miracle Network to have this custom-built, child-friendly mobile clinic.
That's really cool. Wow, those are some overachieving medical students.
And now fast forward 4 years later, with the pandemic, the supply chain was a little bit slow in terms of building the wheels and the chassis of the van. But anyway, the van was finally built. This past year was the first year we were able to take it out into the community. So how it works is, well, we identify the community partner, and through a long process, which is important, by the way, of trust building and demonstrating trustworthiness with a community partner, we then decided to partner with a Folsom Cordova Unified School District. Folsom Cordova Unified School District identified a high-need community in Rancho Cordova, which is why we've been in Rancho Cordova for the past year, and we will continue to be. And so we take our mobile clinic out once a week to a centrally located school site, part of Folsom Cordova Unified School District in Rancho Cordova, to provide pediatric consultative care in child development behavior, mental health, and asthma. And how the referral system works is the school district actually identifies the children and then refer to us. So the referrals from the school district actually come from parents, school counselors, school nurses, teachers, right? So it's a different referral base than maybe what you and I think about.
Totally.
These are not primary care physicians who are finding these children of concern, right?
Yeah.
These are families, teachers, counselors. And then once we get the referrals, we then triage to our 3 clinics in child development behavior, asthma, mental health, et cetera. And then finally, when we have triaged them appropriately, the school district reaches out to the family to say that we have some appointment dates and times to connect you to the pediatric mobile clinic. So you can see that the partner is really at the center, and this is the center of trust to then connect the families to us.
Interesting. So the parents then come in on
Yes.
those times.
Yes.
And you guys park in front of the school and
Absolutely right. Well, we try not to park right in front of the school to avoid the traffic of,
Yes, fair
and
enough.
getting, the dangers of having children around a big vehicle. But we do have the pediatric mobile clinic strategically placed in a large parking lot in the back of the centrally located school site. And we've been going there every Thursday during the school year. So students, families, the community know that we're coming and we're on our way.
And so when you come, do you bring representation from all 3 of those specialists? Like, is there you, a pulmonologist, a nurse, a mental health worker? Like, who's on the bus with you?
We do go out once a week. However, because we have specialists of all these different areas, we actually separate the clinics so that, for example, the Mind Institute and their developmental behavioral pediatrics team comes out once a month. The general pediatrician and the mental health specialist in an integrated way come out twice a month to ultimately even refer patients with initial screening to either the Mind Institute, and then the last clinic of the month is the asthma clinic. And so it's almost like we have our microcosm of a general primary care kind of and mental health screening, and then it refers internally to our specialists.
So the clinic doesn't have to have a whole lot of other medical equipment. You just have to have a safe place to have that. Is that fair to say?
Great point. And so what is wonderful is that Again, we have students coming to the van saying, hey, can I give blood? So it's a very safe, it's wrapped with this beautiful crayon-drawn pictures on the side of the van. So it's a very safe place. It's not at all looking like a hospital, right? And so people come to the van, and the van itself is actually fully equipped once you go inside the van with 2 full exam rooms, fully outfitted with Wi-Fi, hotspot, so we can connect to our Epic electronic medical record, Care Everywhere, so we can see who the PCP is, potentially, your primary care doctor, and then connect them up immediately with our recommendations, right? The other thing that's so amazing, because we are an extension of the Children's Hospital, is that the resources from the Children's Hospital come with us. So that includes the telephonic medical interpretation system, right? So we're not obviously using families, right, to interpret. And we also have a social worker who comes out and joins us. We also have the mental health therapist from the Care Center, which is the amazing trauma assessment and a treatment center right at UC Davis, who are joining us as well. So we have this cadre of specialists who come out to really comprehensively assess and ultimately connect them to resources.
This sounds wonderful and slightly costly. You mentioned the Children's Miracle Network helped to pay for that original grant in the bus, which I think is fantastic. And I've seen the advertisements in Costco and given some money at Costco. But I assume that this is an ongoing funding need. How do you guys stay funded?
I love it. Thanks for giving to the Children's Medical Network, by the way, Julia. And by the way, for our partners listening right now, this is an example of a health service of unmet need in the community that Children's Miracle Network funds. And so through the continual generous funding of the Children's Miracle Network, this proof of concept of having specialists join in the community with community partners is still being funded today.
Oh, that's
by the
cool.
Children's Miracle Network.
Okay.
However, in looking and re-looking at kind of how mobile health vehicles are funded across this nation, about half of them are funded philanthropically, like ours. The other half are funded through the hospital system, cost of doing business, right? And or federal dollars, state dollars, and health insurance plans are kicking in as well.
So how is this working out? Like, are you finding that there's a lot of need in the community and teachers who are not traditionally making these types of referrals know how to do it and find the right patients for you? Or kind of walk us through what is working out here?
I will tell you, with our first pilot of the past, 6 months of starting of this past year, we saw 42 students. And of those 42, 15 of them came through our general primary care and integrated mental health clinic. And of those 15, they all received a general kind of health assessment, but also maybe even facilitated their entry to school to begin with. Some of our pre-K 4-year-olds, they need these school entry kind of assessments. And because they couldn't get into their primary care doctor, you're having that delay of entry into school because of the appointment issue. And so we were able to, of those 15, get these pre-K students in, and then even some sports physicals. So there's pre-participation athletic physicals. Again, because of the appointment delay and time to get appointments, we were able to conduct some of these assessments as well. And so that's just an example. Even if they're, quote, healthy, not needing a specialist, we were still able to do these general health assessments and mental health assessments and get them where they need to go. I wanted to reflect on a couple other, those specialty clinic outcomes that I thought were important to highlight. We diagnosed 7 students with new diagnosis with autism.
Wow.
And it kind of reflects the unfortunate, where we are right now. And no, maybe I should say fortunate, not unfortunate. But the reality is California is doing right by early identification. So we're showing teachers, we're giving them in-services of these are behaviors potentially of children who have autism. So send them our way. And they did that. And we found 7 new diagnoses of autism. Some of them early in age, many of them had missed the window of opportunity. However, 7 now have a new diagnosis of autism and are now on the journey and the roadmap to resources, right, that children with autism oftentimes need. And then in terms of mental health, we identified 6 students with anxiety who had not yet been connected to resources in the school, and 4 of them had significant trauma that needed enhanced mental health support that could not be given in schools. And then lastly, with the asthma clinic, we diagnosed 1 student who was newly diagnosed with asthma and got him on his way. And then the second student who had uncontrolled asthma, but after visiting our asthma expert, then became controlled.
Nice. That can really make a difference for those kiddos day to day, and also staying out of our emergency departments where hopefully they can just focus on living life and being happy, healthy kiddos.
That's right. So we welcomed a diverse group of patients to our clinic. A third self-identifying as Latina, 1/4 is Black, 1/5 is white, and 1/5 is Asian. 40% of our patients came from families whose primary spoken language was not English. 1/4 were either uninsured and certainly eligible for Medicaid, and 1/3 had Medicaid coverage. I did want to emphasize to Julia that all patients who visited our clinic received specialty recommendations to take back to their primary care providers, and these recommendations were also shared with the school referral team so they could integrate it into their own educational plan and potentially use the information for educational accommodations for these 42 students.
Yeah, that's fantastic. Really practical. Okay, sounds great for an academic center, lots of resources. Is this something that is transferable to other communities, maybe even more urban location or even a rural location? Is this something that you think other communities could benefit from?
Absolutely, Julia. We know that across the nation, actually, mobile health clinics are already being deployed by many university-affiliated organizations like ours, but they're also being increasingly deployed by non-academic organizations. And the goals are the same, to ensure access to healthcare for historically marginalized communities. So examples of other non-academic organizations are faith-based organizations, health insurance plans, and even independent organizations.
Yeah, that's interesting. I hadn't realized that other systems were primarily driving that. But I mean, I think it makes a lot of sense and is a fantastic way to do that. What advice would you give other departments that were considering launching a similar program?
I think, Julia, the most important advice I'd like to share with our audience today is how critical it is to take the time to truly partner with the community and demonstrate our being worthy of their trust. And what does that mean? That's time. That's hoofing it to the latest community action board meeting. That's listening at the school nurses district, meeting about what their needs are. That's listening to parents at the PTA meeting. We've done all that. And, listening to our community, learning about the strengths and needs of the community, and being intentional about co-creating programs and evaluating our program has been so critical to the success of our program so far.
Is that where you figured out those 3 focus areas?
Absolutely
by
right.
Listening a lot?
Absolutely right.
Interesting. Where do you see the future of mobile units going over the next 5 years?
Julia, I think the mobile health clinic movement is only going to keep growing. Our team and I, we now have experienced firsthand how mobile clinics can reduce barriers to healthcare, like transportation issues. I mean, the crazy complexities of our healthcare system, of insurance, that whole system, and then also just the general community mistrust that exists. I think we'll continue to see healthcare systems partnering with community organizations to go beyond the walls of the clinics and the hospitals, right, to really, really promote health in the community. And I think our mobile clinic is a great example of that. I mean, we are leveraging, as you mentioned before, the strengths of a large children's hospital in our region, and then partnering with the community to really kind of promote the health and reach the goals of their community, of their children, and what they see.
I really love the partnering and the listening component of that as well. Okay, so that's mobile clinics in general. What about for your team? What are you guys going to be doing over the next 5 years?
Oh, man, Julie, we're obviously going to head back to Rancho Cordova. The school year has started again, and so we'll be doing our weekly clinics there. However, through our lessons learned and what we learned from the community this past year, we are now moving from a proof of concept to moving into other communities in Sacramento of high need, including Del Paso Heights and South Sacramento.
Oh, that's really great. That definitely is an area that's in need, and wonderful to hear that you can expand those services. Cool.
And these 2 neighborhoods are actually aligned with UC Davis Health's anchor institution mission as well. And so we're completely going to be reinforcing and aligning ourselves as an institution, as a children's hospital, and now as partners in the community.
Well, Serena, I love the idea of meeting kids where they are. And I am grateful that there are teams like this working to prevent kids from coming into the emergency department by optimizing their care where they are. This is another episode in our series on medicine on the go, breaking down the walls of our hospitals and meeting patients where they are. Thank you to UC Davis for reimagining how and where we care for patients and supporting people like Dr. Yang, who put the patient in the center of every decision. And thank you to OM Productions for reimagining how we podcast. Until next time, stay curious, stay inspired, and stay tuned.
The opinions expressed on this podcast are those of the hosts or guests and do not necessarily reflect the views of UC Davis Department of Emergency Medicine, UC Davis Health, or their parent organizations.